Okay, and we're back. Um, Welcome everyone. It's Dr. Towfigh again. Sorry, there was a glitch. Um, we are talking today about symptoms that you never thought would be due to your hernia. And the goal today is to go through everything that I know that can be related to your hernia that most doctors and patients and even ChatGPT do not or does not know can be related to your hernia. Okay, so for those of you that are joining me on as a Facebook Live, it's on my at Beverly Hills Hernia Center site. So that hopefully is working okay with you all because the Dr. Towfigh site for some reason didn't work. Anyway, let's talk about abdominal wall. So this week alone, and as you know, most of the time when I do these episodes, I pick and choose based on like patients that I've seen. And that's how kind of topics come up. So today's topic is based on multiple patients that I've seen that they were seen by another doctor, right? So they didn't come to me for their hernia. They were seen by a gastroenterologist. Okay, you hear me now? Okay, you can hear me now. I'm going to stop moving this microphone. Okay, so thank you very much for telling me that you lost my sound for a second. So basically, I've had multiple, let's start with something simple. So this gentleman uh came to his GI doctor mostly for bloating. And of course, there's tons of GI reasons for bloating. And what's going on here? And why am I no longer live on Facebook? This is horrible. Looks like I'm no longer live on Facebook. Why is that? This is so crazy. Let me try one more time. I'm so sorry, you guys. Okay, we'll try it. If it doesn't work, we'll post it on Facebook. So, okay, so here's the situation. He went to his GI doctor with bloating. And of course, there's a million different things that can cause bloating. It could be stomach ulcers, commonly gallstones. You can have an infection or something, food poisoning, H. pylori, infection of the stomach. And then there's other things like SIBO, like small intestine bacterial overgrowth. And so based on that, he went to the GI doc. GI doc said, yeah, it could be this, that, or the other. And let's do endoscopy, colonoscopy, normal. So they're kind of scratching their head. And this GI doctor is really smart. And he did a full workup, couldn't find any reason for the guy's abdominal pain. So he sent him to me. And not because there was a hernia issue, but specifically because I like to figure out abdominal pain of unknown etiology, and that's kind of like a thing I like to do. So he sends them to me, and I look at the guy's belly button, and I can't say it's an outie because he actually has an innie, but there's a little bulge with like fat that's stuck in his belly button hernia. You know, a lot of people have that. So I started asking him questions, and it turns out he he was doing fine until COVID. And during COVID, he had um an event where he felt like a pop coming out of his belly button, and then In retrospect, he didn't really correlate like one versus the other, but these were his symptoms: bloating, generalized abdominal pain, sometimes to the upper abdomen, but mostly around the mid-abdomen, so belly button, hello. And it was mostly to one side of the belly button. Oh, and back pain. So guess what? Belly button hernias, which a lot of people have, and most of them do not need to be repaired, can cause these enigmatic kind of mysterious pains. They can cause bloating. Actually, it's not necessarily because there's intestine in the hernia, although that will definitely cause bloating and maybe even intestinal obstruction. But the bloating is a response to the pain from the hernia. It can cause back pain. So usually it shoots straight around at the same level as the belly button towards the back. And some people, you fix their hernia and they're like, wow, my back pain's gone. And classically, people think that the belly button hernia should hurt at the hernia. I don't know why, but there's a very large proportion of patients that I see where the hernia isn't where the pain is, but it's to the side, left or right. I haven't seen a correlation. But these are common symptoms that isn't ever in any textbook about belly button hernias. In fact, most people are saying you don't need to fix those hernias. But if it does bother you and if it hurts, you should get it fixed. So that's the belly button. We had an earlier question about steroids and whether steroids can cause abdominal, like worsening hernias. Unlikely. Epidural injections, whether that could cause hernia pain or worsening, definitely not correlated or anything related to that. Now let's go for, let's see, what other hernias can we talk about that's kind of not, well, before we go on to the, you know what, let's do it. Let's just go on to the groin hernia. So groin hernia, this is, my baby, right? I really like groin pathology. So what's interesting is male and female can both have groin hernias, inguinal hernias, and they can both also have what's called radiating pain. So radiating pain means the hernia is not just at the groin or at the hernia, but it can shoot. So in men, it can shoot into the testicle. It can wrap around to the lower back. It can go up to the hip. It can go down the inner thigh. In women, it could shoot into the vagina. It can go down the inner thigh and also wrap around the lower back, more commonly than men, at least in our study, which we published. And bloating can be seen both males and females with groin hernias, as well as belly button hernias and other hernias. Again, the bloating is not necessarily because there's intestine involved, but it's a reaction to the pain associated with the hernia. And then the pelvic floor spasm. This one is not very commonly appreciated. So inguinal hernias, not so much ventral hernias or abdominal wall hernias, inguinal hernias in the pelvis can cause pelvic floor spasm. Now, what's the pelvic floor? So the pelvic floor, I describe it like a salad bowl, and it's your whole pelvis, you got the bones, and then there are these stirrups that kind of hold all your organs within your pelvic bones. These are muscles called the pelvic floor. These muscles can go into spasm. What does that mean? That means like same way you can get like a groin stitch or like a calf that gets hurt or spasmed, or you can get neck spasm. Your pelvic floor can also spasm. There are 3 organs that go through the pelvic floor. The rectum, in males and females both. The rectum there's a hole in your pelvic floor for your anus, okay? When you urinate, the urethra in both males and females empties the bladder, goes through a hole through your pelvic floor, and you urinate. And in women, there's a 3rd organ, which is the vagina. So the uterus then exits via the vagina, which goes through the pelvic floor muscle. So if you have pelvic floor spasming, any of those 2 or 3 organs will also feel the spasm. So most commonly, it would be urinary symptoms. So either urinary frequency. So I've had a woman, she would urinate 40 times in one night. She couldn't sleep. It could be painful to urinate because you're trying to urinate through a tube that's constantly being like obstructed with the spasm of the muscle. There's some thought that pelvic floor spasm causes kind of higher pressure and maybe even irritation of the bladder and therefore interstitial cystitis. So now we have a situation potentially where the interstitial cystitis is due to pelvic floor spasm and the pelvic floor spasm is due to the hernia. So if you have interstitial cystitis, you may have a hernia. If you fix the hernia, the pelvic floor spasm will go away, which may eventually heal your bladder. Never been proven, but anecdotally, we have patients where that's been the situation. The rectum is not as commonly affected by pelvic floor spasm, but it can be. And the way it is usually it's like painful to have a bowel movement. And a lot of people have pain with bowel movements with their groin hernia. And in women, the other issue is their vaginal pain. So any intercourse will be painful because the muscle around the vagina is very stiff and not accommodating. And so there's some sexual dysfunction. And so the female goes to their gynecologist or medical doctor. They may correctly diagnose the patient who has vaginismus, which means kind of like a spasm of the vagina or painful vagina, or vulvodynia, which is like kind of or pain around kind of the outer part of the female genital system, or vaginal, term for vaginal pain. I don't want to say vaginodinia. There's another term for it. There are all these kind of pain symptoms for women. And then they may also go to a sexual function specialist, who's usually a gynecologist, sometimes urologist. And most of them, I would say, are not aware, but many of them are, that pelvic floor spasm will cause the sexual dysfunction, and then they send the patient to a pelvic floor muscle therapist, like a pelvic floor therapist, a physical therapist that focuses mostly on the pelvic floor, which is a very complicated area of the body. And guess what? That patient, if the hernia was causing the pelvic floor spasm and therefore let's say the sexual dysfunction or the urinary frequency or the rectal pain with bowel movements, that person hates going to physical therapy for their pelvic floor because it's not helping the hernia. They're trying to focus on the pelvic floor, but it's painful. So some people get Botox into the muscle to address the pain. Some people get vaginal suppositories or rectal suppositories to help kind of infuse like a muscle relaxant through the suppository and so on. And unless you fix the hernia, if that's the cause of your pelvic floor spasm, none of your downstream effects will get better. Vaginal tenesmus. Yeah, we call that vaginismus. That's when you have pain within the vagina. Yes. But there's another term too. I'm trying to remember. Vulvodynia. Anyway, I'll come up with it. Okay. In both men and women, there are nerves that run through the pelvic floor. And that nerve, the largest one and the most difficult one to assess, is called the pudendal nerve. So many people who actually have groin hernias are diagnosed with pudendal neuralgia. Now, what's pudendal neuralgia? Neuralgia means nerve pain, so nerve pain of the pudendal nerve. Now, the pudendal nerve, like all other nerves, starts in your spine and then comes out and around towards the front. And it goes through the pelvic floor muscle and it sends out branches. So it sends out a branch to your rectum, to your vagina, to your perineum, to your in males to the penis, in females to the clitoris. And pain along any of that may be due to your pudendal neuralgia. Now, what's important to know is in most people, I would say the majority of people, their pudendal nerve is totally normal. People who get injury to their pudendal nerve, either they had a major trauma with lots of muscle and nerves being injured and torn, especially like, let's say, a pelvic fracture. They may be wheelchair bound and sitting on their butt, and their butt muscles are not strong because they've been wheelchair bound for whatever reason. So atrophied muscles, so you're basically sitting on the nerve and putting a lot of pressure on it. Fun trivial fact, pudendal neuralgia was first diagnosed in World War, I want to say one. The soldiers were in Jeeps, but the Jeeps had metal seats. There was no cushion. And so their coccyx and pudendal nerve, I guess, was constantly being kind of pushed on and on these bumpy rides because they're sitting on metal. And many of them had pudendal neuralgia. So that's a direct trauma to the nerve. Bicyclists, professional bicyclists on that really very, very painful, narrow bicycle seat can get pudendal neuralgia if there's sitting in a way where there's direct, very pointed pressure on the nerve. So those are all examples of pudendal neuralgia where there's actually an injury to the nerve. But if you just a normal person and there's no reason for you to have had injury to your pudendal nerve, what can happen is the nerve, like I mentioned, courses through the muscle, the pelvic floor muscle. So if your muscle is in spasm, that's going to also stimulate or irritate the nerve, otherwise normal nerve, but it's running through muscle and the muscle is spasming, and therefore you will have stimulation of that nerve abnormally, and you may have penile pain or clitoral pain of sorts. A tip of penis pain is one of those. So fixing the cause of the pelvic floor muscle spasm should address the clitoral pain, let's say. And if it's a hernia, the hernia is causing the pelvic floor spasm. So check this out. Potentially, you can fix a hernia and cure someone's clitoral pain or tip of penis pain. How cool is that, right? So this is kind of like things that I'm learning and I'm hoping to share, and then I collaborate with my gynecologists, urologists, pain doctors, and they get all excited because then they're like, oh my God, I've had, let's say, this many patients in the past year who potentially that's their problem now. So very, very cool situation. Now, more nerve stuff. If you think of a groin hernia, and we discussed this actually, this is not as like uncommon to know. Most doctors should know about this, even though the majority still don't. I should say some doctors should know about this, even though majority do not. So the ilioinguinal nerve is a nerve that starts in the back again, comes out and around in the front, and in men gives sensation to the base of penis and the inner thigh. In women gives sensation to the mons and the labia and the inner thigh. And in those patients, oh, before I move on, here's a question. Can isolated pain in the groin and pubic bone in males without rectal, penile, and perineal pain be due to pudendal neuralgia? No, but I'll tell you what it can be due to. My surgeon is attributing post-herniorrhaphy pain to pudendal neuralgia. Yeah, that's incorrect. So if you've had a hernia surgery and now you have pudendal neuralgia, those two are not related. So there's 100% zero possibility that the pudendal nerve can be injured from a hernia surgery. It's just not where we are. The nerve runs within the pelvic floor. We're nowhere near the pelvic floor. And it enters from the back to the front, which is not where the any of the surgery that we do addresses it. So no. Now you can have pudendal neuralgia and separately had a hernia repair. And now they're trying to say, well, the pain is not from your hernia, it's from your pudendal nerve. But if you had the pain only after your hernia repair, that doesn't make sense for it to be due to something other than your hernia. I hope that makes sense. Okay. So where was I? Oh, ilioinguinal nerve. So the ilioinguinal nerve travels between two, like a fascia and muscle layer. It's also the same layer in which a hernia travels, which is called the inguinal canal. And so if you have something bulging like a piece of fat in the hernia, guess what? Now you're competing for space between that piece of fat and everything else that's there. So it could be the ilioinguinal nerve or the genital branch of the genitofemoral nerve, because that travels with the hernia sometimes in the internal ring anatomically. So the hole is called the internal ring through which the fat goes, but it's also half the time where the genital nerve goes as well. And then secondly, as the fat comes further out, it can now also interact with the ilioinguinal nerve. So many people have either ilioinguinal nerve pain or ilioinguinal neuralgia, which I said is base of penis and inner thigh, or in women, kind of labia mons and inner thigh. And in both men and women, it can wrap around to your lower back, following the track of the nerve as it goes toward the spine. But people don't just wake up with nerve pain. I say that all the time. You can't just be normal and then one day have nerve pain. That doesn't happen. But you can wake up one day with hernia pain, and your hernia pain can be small enough that's just not large enough to see the hole, to see the fat coming out or the intestines coming out, but enough to put pressure and irritate the ilioinguinal nerve or the genital nerve. The genital nerve in women causes sensation to the labia, and in men causes sensation to the scrotal skin. So hypersensitivity to the labia or the scrotal skin can be due to a genital nerve irritation from a hernia. Do not address the nerve. I see people who get neurectomies, so the nerve is cut. I see people that get nerve ablations, like they have either cryotherapy or radiofrequency ablation, where their nerve is either frozen or burnt. I see people that get nerve stimulators implanted in their spine or their groin for their nerve pain, and they're given tons of narcotics and nerve pain muscle. All they need is a hernia repair. We have to understand these are all secondary problems. The primary problem is the hernia, and that's why I'm doing this episode, because there's so much I can share. This is going to be one of our best episodes, because there's so much that I can share where people don't, and textbooks haven't made the correlation between pain and a hernia. Okay, let's answer some questions. Can you get a new hernia even though you have two meshes? Yes. That'll be a hernia recurrence. I have a mesh for incisional hernia by my navel. Now I have another hernia there. Yes. So what you're describing is a hernia recurrence. So any hernia repair, whether it's with or without mesh, has a risk of recurrence. In most situations, the recurrence rate is significantly lower if you had mesh than if you did not have mesh, but it's not zero. And depending on your risk factors, you may be at higher risk for recurrence than the average patient. What are some risk factors? Being ill, not having good diet or protein, being morbidly obese, diabetics, any sort of infection, nicotine use, those are all risk factor, or obstructive sleep apnea. Those are all risk factors for having a higher risk for recurrence, even if it was a perfectly good repair with mesh. Here's another question. Going back to the question about pudendal neuralgia as a cause of post-inguinal hernia or pain, the surgeon said preoperative pain was always pudendal neuralgia and not from the hernia or the hernia surgery, but I have no involvement of the perineum, penis, or rectum. What do you think? I think they know what they're talking about. Pudendal neuralgia does not just occur. You have to have an actual injury to the nerve. And what is that injury? All those that I explained. Trauma, surgery to the somehow went awry and scraped the nerve, and so on. So if you have, so pubic bone pain is not pudendal neuralgia. And groin pain is not pudendal neuralgia. Pudendal neuralgia is very specific. It's tip of penis pain in males and urinary frequency, not urinary frequency, rectal pain and perineal pain. It's very, very specific nerve. So yeah, I have a feeling you need someone a little bit more knowledgeable about these problems. Okay, so we talked about the different nerve pains. And again, I've had patients who've had triple neurectomy, okay? Triple neurectomy, and now have permanent nerve damage, and all they had was a hernia. And they missed the hernia. I've had surgeons that operate on nerves twice, to the point where the patient is now wheelchair bound because of the pain from her hernia was never addressed, and now she has neuromas from the nerve surgeries. So there's none of this is in the books, and we don't have a good database or questionnaire to capture all of these questions. I'm doing my best, like I published on it, but I'm just one person, and we don't have enough surgeons like me that 100% devote their time to sit down with the patient and ask these questions. So half the surgeons will say, if you don't have a bulge, there's no hernia. Anyone who follows me knows that's completely incorrect. And you need to, it's just logic. Like there's a spectrum, right? You don't go from 0 to bulge. Between 0 and bulge, you're going to have a widening of the hole, little piece of fat in there, a little more piece of fat in there, more widening of the hole, a little more piece of fat. 10 years later, you're going to have a bulge. But between that time, you may have other symptoms, because as the hernia is taking up space where it shouldn't, it's interacting with other things. So we already talked about the nerves it can interact with, because those are also sharing the space in the inguinal canal. That's specifically the ilioinguinal nerve and the genital nerve. It's never the iliohypogastric nerve or the obturator nerve. However, one thing I didn't discuss is in men, what else goes through that internal ring, that ring where the hernia goes through? The spermatic cord. Are there nerves in the spermatic cord? Yes. What nerves? The vas deferens, which carries the sperm from the testicle to the prostate, has nerves. Those nerves are called vasal nerves or vas deferens nerves. If that nerve is injured or irritated, testicular pain. And so I recently had a young kid who was sent to me by his urologist. Chronic testicular pain. No one can figure out what's wrong. And he's seen multiple urologists. All they kept doing is ultrasounding his testicle and saying there's nothing there. And finally, they got to the point where they offered him to have an orchiectomy, which means the testicle will be cut off. He was offered a spermatic cord denervation procedure, which is a microscopic procedure that cuts out all the nerves to the testicle. Again, when I say the nerve is not the issue, the nerve is normal. It's just being irritated. by the hernia. So one of his urologists was smart enough to say, you know what? I've heard Towfigh talk about this before. Let me send you to Towfigh. I don't feel a hernia, but maybe she can feel a hernia. And if it is, maybe that's the cause of your pain. He comes to see me. I absolutely feel a hernia. Absolutely. So it wasn't, there was no bulge, but you can feel it. And we did imaging, confirmed actually it's a good size hernia, fixed his hernia, and guess what? 7 or 8 years, I think 8 years of testicular pain gone with a hernia repair. I didn't touch any nerves. I didn't manipulate any nerves, gone. So those are things that I hope a urologist who sees a testicular pain, for example, will say, maybe it's a hernia, or a female, let's say gynecologist that sees someone with vaginal pain and pain with intercourse will say, maybe it's a hernia, or physical therapists. They're actually the best referrals. Physical therapists are really good because they will definitely say, oh, yeah, pelvic floor spasm doesn't seem to be getting better. Send them to Towfigh, it may be a hernia. Okay, let's do another question. Let's see. I have a very tight lower abdominal pain 24/7 with feeling of loose bowels. Male 54 keyhole repair. Okay, so keyhole repair refers to hernia mesh that's made into a hole to wrap around the spermatic cord in men. We don't usually do that in women, but you can. So very tight lower abdominal pain 24/7, maybe because of too tight of a hernia repair of your mesh. So replacing the mesh may help. And I have the feeling of loose bowels. If they cut any nerves, that could be a problem, but usually that's not the situation. Next question. I had spinal epidural for horrible pain in the right front side on my lower rib. The pain is worse at night and it helps when lying on my side. Now, from what you say, this could be from my incisional hernia by my navel. Yeah, absolutely. Absolutely. If you have an incisional hernia by your belly button or the belly, lying on your some people don't like to lie on their side. Some people do like to lie on their side. It all depends on what's in your hernia, how big's a hernia, and so on. If pain is worse at night, that just maybe you've been upright for too long and that kind of that pain kind of hurts over time and by the end kind of peaks at night. You had a spinal epidural for horrible pain in the right front side on the lower rib. Yeah, that could be from your hernia for sure. Depends on where your hernia is though. Okay, can a damaged nerve by pressure recover enough from damage to relieve pain? So that's an unknown question. The question is this. If you're saying that you have a hernia and the hernia is irritating or putting pressure on the nerve, then you fix the hernia. Isn't the nerve damaged? There is a surgeon up in Oregon, who I think is still in practice, who theorizes that maybe a lot of the pain for patients, even though it's from the hernia, is also due to permanent scarring and damage of the nerve due to the hernia. So he did a study where he cut the ilioinguinal nerve in all of his patients and sent that nerve to the pathologist to do specific testing to see if there's been neuritis, nerve damage, scarring of the nerve, whatever. And he found a very high percentage, I think 60 or 70% of the nerves were abnormal. Now, his conclusion was all patients who have hernias will damage their nerves. So unless you cut the nerve, you're not going to cure their chronic pain after surgery with a hernia repair. Those of us that never cut nerves obviously feel differently from that. And the way I interpret his paper is, yes, hernias indeed do irritate and perhaps even damage, unlikely damage, it's hard to damage a nerve, irritate these small nerves. But once you relieve that hernia, that nerve will recover. It's possible it won't recover in a fraction of patients, but the nerve will not recover. And so what his study cannot prove is if you didn't cut the nerve, will that same pathology just recover? Because nerves recover. Nerves, there's a tendency for it. So the question, can a damaged nerve by pressure recover enough from damage to relieve pain? From a hernia, it should. I believe it should. But there is at least one study or one surgeon who strongly believes that as a surgeon, you should not run that risk. I personally am not for neurectomy if it can be prevented. So talking to the wrong person about nerves. Okay, another question. Inguinal hernia surgery on left side using Schuldeis technique. Okay. I was gradually recovering after surgery. I could sit. About 6 weeks later, my scrotum got hit and was injured. Then I had pain when sitting. I could not even sit for 1 minute. About 1 year later, the pain has improved. I can sit 10 to 20 minutes, but not fully recovered. Recent ultrasound found hernia recurrence. What should I do to fix the pain when sitting? So a hernia recurrence or any hernia can cause pain with sitting. Common symptoms of groin hernias include pain with sitting, pain with bending, pain with prolonged standing, and pain with certain activities like long walks and going up and down hills and things like that. So it sounds like, yes, you had a Schuldeis hernia repair, one event. Yes, you had a scrotal injury, should not have caused the hernia recurrence necessarily, another event. And now you have a hernia recurrence, which I relate to the first event, and is being clouded by the story about your scrotal pain. So if you have a hernia recurrence that you can see on ultrasound, that's almost always correct. You should believe it. If your symptoms correlate with that, such as pain with prolonged sitting being a result of hernia recurrence, then now you have two findings which are suggestive of your hernia recurrence causing your chronic pain, which can also give, by the way, testicular pain, usually not scrotal pain. Although at the Schuldeis, if this were done at the Schuldeis clinic or by a Schuldeis trained surgeon who routinely cuts the genital nerve, you can get scrotal skin sensitivity. But most likely what you were describing is testicular pain, which can be due to inguinal hernias or recurrence, as we mentioned earlier, right? So the hernia comes out, it irritates the genital nerve, and you get testicular pain. And so the question is, what is the status of your genital nerve? Was it cut, which is routinely done by the Schuldeis clinic and most Schuldeis trained surgeons, or do you have an intact genital nerve and it's being irritated by the hernia recurrence? Okay. So this is kind of the bulk. Let's see, what have I missed? Couple things. Obturator hernia, very uncommon. Happens typically in a frail elderly patient that has constipation, a lot of abdominal pressure. It's not normal to have an obturator hernia, but many people have pain due to the nerve that runs through the obturator canal is being pinched by the fat from the obturator nerve. So easy. That is in the books, by the way. It's called Obturator Neuralgia, and it's pain, burning to the inner thigh at the level of the knee. So not the upper inner thigh, which we see with Ilioinguinal Neuralgia from an inguinal hernia, but distal, like further closer to the knee, far away, lower part of the inner thigh, closer to the knee. That's called obturator neuralgia. So people with obturator hernias usually don't have a bulge because it's kind of down lower in the perineum area. But what can happen is it presents with the kind of hypersensitivity there. So they see the orthopedic doctor because they call it knee pain. Then they see maybe a spine doctor because they call it like radiculopathy or pain from your spine, like an L4 situation. And it's always like a hernia upstream from that. All right, here's clarification to our most recent question. Yes, one nerve is cut, done at the Shouldice Clinic. So that nerve is usually the genital nerve. The genital nerve, when it's cut, you can get numbness of your scrotal skin. So if you have numbness of your scrotal skin, that's just part of the surgery. If you have pain at your scrotal skin, that could be from a neuroma from your genital nerve being cut. Low likelihood, but it's a possibility. But if it's testicular pain, that's from hernia recurrence. So any hernia can cause testicular pain. And so I would treat the hernia to treat the hernia recurrence. And that should take care of all the downstream. So the moral of the story is, if you can figure out and solve the puzzle of your pain, whether it's abdominal pain, back pain, rectal pain, clitoral pain, vaginal pain, testicular pain, knee pain, if you can figure out that pain to be potentially caused by an inguinal hernia, then please don't go to a pain doctor or urologist or gynecologist for another procedure other than your hernia repair. I'll give you one last clinical scenario. You've heard me talk about hip disorders and sacroiliac joint or SI joint problems as kind of one of these problems that you always have to think about when evaluating someone with groin pain. So now this is the reverse. This is someone with an obvious hernia that we have to say, okay, hold on. I see you have a hernia. Question number 2 is this hernia causing you pain? And it's so common to see people that have hernias be sent to a general surgeon who says, hernia, let's fix it. They fix the hernia and their underlying pain is still the same because it was never their hernia. It was their hip, or it was the SI joint, or it was their lower back, like kind of mid lower back, like L1, L2, L3 disc disease. Okay. So you don't want to be that surgeon that does an unnecessary procedure. Worst case scenario, you did the hernia repair on a patient that was technically had no symptoms from the inguinal hernia, but had this other hip or spine disorder. And now you have a complication from the surgery. Let's say the mesh balled up, also known as meshoma, you injured a nerve, whatever. And then the patient has their original pain, and on top of that, chronic pain after their hernia repair. That's like worst case scenario. And it happens. I see at least a dozen of that a year in my practice. So what if this is this recent scenario? Imaging shows a little bit of disc, L1, L2. A fair amount of hip problems, like a little osteoarthritis of the hip, maybe a labral tear of the hip, a hip click, right? Hip clicking. And then lastly, a groin hernia. And your main symptom is groin pain. Oh, and you have a inflammation of your sacroiliac joint, SI joint. All 4 of those can cause groin pain, by the way. So what do? Do you get your hernia repaired? Do you get your hip disorder repaired? Do you get your spine surgery? Do you have your SI joint operate on? Here's my take on it. I like to do the least invasive procedure first and try and rule out as much as possible. So least invasive would be inject the spine, inject the sacroiliac joint, inject the hip, and see each time which one makes you feel better. And gear it towards that. If you have a situation that there's more than one causing the pain, so let's say you have your hernia hurts and you have a hip disorder, my recommendation would be fix the hernia first. Because of all those procedures, hip, spine, SI joint, my impression is a hernia repair is the least, how should I say this? It's the lowest risk procedure. Let's put it that way. So let's fix the hernia, take that out of the way. You may say, oh, I'm cured, right? My back pain is gone, my hip pain is gone, my leg pain is gone. Or you can say, okay, my groin pain is better. The pain radiating to my inner thigh is gone. The pain into my vagina is gone. But I still have some back pain, for example. Then you can focus on the other stuff. That's kind of how I go about it. And I work very closely with the orthopedic doctors and the neurosurgeons and the pain management doctors to try and figure this all out. Let me do this one last question. Shall I do a MR neurography to see if my pain when sitting is due to a muscle or nerve injury and to confirm the hernia recurrence? The MR neurography is the imaging of peripheral nerves based on magnetic resonance imaging techniques, correct. MRN is used to evaluate peripheral nerve disorders such as nerve entrapments and impingements, as well as locate and grade nerve injuries. Not very good for the small nerves, which is what we're talking about. The visual information of precise location and extent of nerve disorders provided by the MRN makes it a powerful tool to help physicians and surgeons to come to an accurate diagnosis and to decide on further medical or surgical therapy. You are a great doctor. Well, thank you. I feel like you went to ChatGPT and asked them what an MRN is. Let me explain to you more. So MRI stands for magnetic resonance imaging. And it's basically a cool way to look at most of your soft tissue, some tumors. It's great for hernias because it's a soft tissue issue. And it shows mesh separate from muscle, muscle separate from fat. It's great. MRN is magnetic resonance neurography. So they manipulate the MRI so that the nerves look bright on it. Now, it works great for the larger nerves. So spine, sciatic nerve, pudendal nerve, all the big nerves. But once you get to the front of the groin, the nerves have split. So it's like really tiny, much like, I'm not going to say hair-like, but maybe like, it's like maybe 10 hairs worth or 5 hairs worth. Very, very thin. So if you have a genital nerve neuroma, okay, if it's big enough, big nerve neuroma, it will show up on MRI as MR neurography. It may also show up on an ultrasound. However, it is not diagnostic for most people with chronic groin pain. An MR pelvis can, oh, and by the way, most MR neurograms focus on the back and the side and not the front. So that's another like negative. And number 3, it's really hard to interpret MR neurography, so it has to be done in an institution that does it often because the radiologist needs to know really what they're doing, and the doctor needs to talk with the neurologist, like the neuroradiologist, and kind of make sure that they're very clear where we want them to look. It is not a good study for patients with chronic groin pain. In general, MR pelvis will help identify the hernia recurrence. You already have an ultrasound that shows it, so I don't feel strongly about getting an MR pelvis about it, especially if your symptoms, exam, and ultrasound all confirm the same thing. So that's where it is. I used to do a lot of MR neurograms early in my stage, kind of in the year 2002-ish. And it never helped me, to be honest. It's kind of cool. I thought it'd be a great idea. I never saw any nerve pathology that I could have said, ha, that's where it is. The nerve isn't trapped, the nerve isn't pain, there's a neuroma. It was never that. So I've moved away from MR neurogram. I get maybe one a year at most, and that's even pushing it. Okay. Sorry for all the stuff early on. We had a little bit of a glitch with Meta, but I appreciate all of you that logged in on Facebook Live and asked me questions on that platform and on the HerniaTalk Live platform. I really appreciate it. I have fun with these guys, and I really appreciate that many of you actually log in because I'm always amazed. I think we hit 40,000 downloads or something like that. Something enormous. And I'm really proud of that because it's all because of you guys doing it. And thank you for watching. So that's the end of our show. You know what? Let's do one last question because I'm being generous. Hi, Dr. T. I'm a 58-year-old male, ileostomy in 2020, reversal in 2021. Had a stoma hernia. The hernia was repaired 3 times in 2022. Did they use mesh? Why did it take 3 times? Now I have a complex ventral hernia with occasional bowel obstruction. I do have intense cramping during intercourse and no pain. Is this something that can be addressed during surgery, hopefully robotic? Referral with Dr. Orenstein next month. Thanks for listening to you. Okay, Dr. Orenstein's great. Sean Orenstein at Oregon Health Sciences University. He was one of my guests. Feel free to listen to him on one of my prior podcasts. Just look up the name Orenstein Hernia Talk. I would try and figure out why you recurred. Oh, 3 hernias at once. Okay, not 3 separate hernia recurrences. Now I was concerned about that. So let's see. So it sounds like you have a recurrence which needs to be addressed, and cramping during intercourse but no pain. If it's abdominal wall cramping, that may just be from the hernia because it's trapping things while it's trying to contract. So yeah, fixing the hernia should hopefully deal with all that. And that, my friend, is the end of Hernia Talk tonight. I will see you next week. I'm on a roll. I'm getting a lot of friends coming on soon so you can get to know even more hernia surgeons. And I hope you all enjoy a great evening. Talk to you later. Bye.